Hello all. Today we will continue with our stroke localization part 2. In the last session we have studied some basic concepts we should know before going to the localization. Okay. So in this session we will be handling about how to localize a stroke and some important things. So some basic things. With this basic things you can localize a stroke. Okay. Okay, first of all, we should know where are the locations. Okay, so first of all, it may be at the level of a cerebral cortex. It may be at the level of a cerebral cortex, at the corona radiata, at internal capsule, or at the level of the brainstem. In the brainstem, it is again divided as midbrain, pons, and medulla. Okay. Now, first of all, coming to the cerebral cortex, a lesion in the cerebral cortex. Okay. In a patient with a lesion in the cerebral cortex, the symptoms will be differential hemiplegia, seizures, aphasia, corticosensory loss, bladder abnormalities, higher mental function abnormalities. Okay. A differential hemiplegia means here the hemiplegia is not dense. It is not same in the everywhere. It is not equally distributed. Here sometimes maybe the weakness of the upper limb will not be equal to that of the weakness of the lower limb. Okay, there may be a differential hemiplegia. Okay, a differential weakness. It is not dense or it is not equal in every part. Okay. Now next is the seizures. Seizures is a sign of cortical lesion. Next is aphasia. Aphasia means aphasia is divided based on some things like repetition, comprehension, fluency. Okay, based on that it is divided into Broca's aphasia, then Wernick's aphasia, global aphasia. There are some more, but I am discussing only some important things, some basics. So first of all, what is repetition? Repetition means if we tell a person to repeat some words, he is able to repeat it or not. For example, if we ask the patient to tell ball, if he is able to repeat it, so repetition is present. Okay, in a normal person, repetition will be present. If I ask something to tell ball, he will repeat it, ball. Comprehension means we are looking whether he is understanding what we are telling to him. Okay, so for that we are asking the point to something that is present nearby. For example, we'll ask the patient to point to a fan nearby, to point to light nearby. Okay, if he is able to point it, then comprehension will be present. Fluency means how fluently he can speak, that is with meaning or without meaning. Okay, fluency is with or without meaning. Okay, in case of Broca's aphasia here, comprehension is present. That means he is able to understand what we are telling. Okay, what we are telling, that he is able to understand. Broca's aphasia is also called motor aphasia. Okay, he is understanding what we are telling, but the problem is his fluency is lost. He is not able to repeat it. He is not able to answer for it because there is some motor problems there. So the fluency is lost. So since he is not able to repeat it, so repetition is also lost. Okay. So repetition is also lost. Okay. So in case of Broca's aphasia is also called as motor aphasia. Here the comprehension has no problem. He is understanding what we are telling, but he is not able to repeat it. He is not able to tell due to some motor problems. Okay, so his fluency is lost, so his repetition is lost. Okay, next is Wernick's aphasia. Here the problem is he is not understanding what we are telling. He is not understanding the meaning of what we are what we are asking to him, but his fluency is present. He's telling something else, something that is not some meaningless words are he is telling. So if we ask a question, what is your name? He may be telling, I am studying in 5th standard. Okay, so his reply has no any meaning, has no any connection with the question. Okay, so that is his fluency will be. Here the fluency is present but the comprehension is lost. Okay, he is not understanding. So if he has to point the fan, he can't point because he is not understanding it. Okay, so the repetition is lost. Okay, next is global aphasia. In global aphasia, all these three are lost. Okay, this is global. Everything is lost there. Okay. Next is the corticosensory. Next is bladder abnormalities will be there. Then corticosensory loss. For that we have to look graphesthesia. Graphesthesia means we will ask the patient to close the eye and we'll write some letter in the hand and ask the patient which letter is it. Okay, then stereognosis. Stereognosis means we'll ask the patient to close the eye and we'll give some coin or something, and if the patient is able to understand this, then so stereognosis will be present. Then tactile localization, that is touch. And then 2-point discrimination all. Next is the coming to the blood supply of the cerebral cortex. If the upper limb, the weakness of the upper limb is more than that of lower limb, the artery affected will be the middle cerebral artery territory will be affected. If the lower limb is affected more than that of the upper limb, then anterior cerebral artery territory will be affected. Okay, so we have to look that whether the patient has a differential hemiplegia or not. Okay. So if it is dense hemiplegia, it is not a lesion of the cerebral cortex, and we have to look if corticosensory loss is there, or is there is any seizure, is there is an aphasia, is there is any bladder abnormalities. This bladder abnormalities will come for other spinal cord lesion on, but these things are must. This hemiplegia, seizure, aphasia and corticosensory loss. You have to look these things. Okay. Next is the corona radiata. In corona radiata also we will there also we will get a differential hemiplegia, but there will be no any corticosensory loss or any seizures will be there in the corona radiata. Okay. Now coming to the internal capsule. Internal capsule, there we have three things. There we have dense hemiplegia. So since all the fibers are converging, in the point, so there we will get a dense hemiplegia. Okay. Then there will be hemianesthesia will be there. Then there will be homonymous hemianopia. Okay, there will be homonymous hemianopia. So what are the three things? There will be crossed hemiplegia, there will be dense hemiplegia, there will be hemianesthesia and homonymous hemianopia. And the blood supply is middle cerebral artery territory. So there also middle cerebral artery territory is the blood supply. Next is the brainstem. In a brainstem lesion, there will get a crossed hemiplegia. That means the hemiplegia will be in one side and the facial nerve involvement or the cranial nerve involvement will be in the opposite side. Okay, cranial nerve involvement will be in the opposite side and facial and the hemiplegia will be in the other side. Okay, and there will be also associated involvement of the cranial nerve also. Next is in a midbrain, the nucleus, there we have the nucleus of the third and fourth cranial nerve. In the pons, we have the nucleus of the 5, 6, 7, 8 cranial nerves, and in the medulla we have 9, 10, 11, 12 cranial nerves of 9, 10, 11, 12. So we have to learn in the midbrain we have the nucleus of third and fourth cranial nerve. In the pons we have the nucleus of 5, 6, 7 and 8 cranial nerves, and the medulla we have the nucleus of the 9, 10, 11 and 12th cranial nerves. Okay. Next coming to the midbrain. In a midbrain we will get a cross hemiplegia, that is and the 3-4 nerve involvement will be there. In a cross hemiplegia means the hemiplegia will be in the one side, one side, and the cranial nerve involvement will be in the side of the lesion. Okay, if the lesion in the left side, the cranial nerve also involved in the left side, and the hemiplegia will be in the opposite side, in the right side. Okay, and third and fourth nerve involvement will get ptosis, diplopia, squint, dilated pupil. Then there will be limitation of the movement of the affected eye when looking inward and downward. Okay, so these are the symptoms we will get: the ptosis, diplopia, squint. These are if there is any third and fourth nerve involvement, we'll get these symptoms. Okay, so there are some syndromes associated with the midbrain. They are Weber syndrome, Cloud syndrome, Perinaud syndrome. Weber syndrome means there is ipsilateral third nerve palsy and there is contralateral hemiplegia. Okay, there is ipsilateral third nerve palsy plus contralateral hemiplegia. Next is Claude syndrome. In Claude syndrome, there also we have ipsilateral third nerve palsy plus contralateral ataxia. We will have contralateral ataxia. Next is the Pedinot syndrome. Pedinot syndrome, we have eyelid retraction, large pupil, light near dissociation, convergence retraction nystagmus, vertical gaze palsy and downward ocular deviation. And we have downward ocular deviation. So at least you should know what are all the symptoms present in the midbrain. That is Weber syndrome, Claude syndrome, Pedinot syndrome. Okay. And the blood supply to the midbrain is posterior cerebral artery, superior cerebellar artery, anterior choroidal artery and posterior communicating artery. Okay. So that is posterior cerebral artery, superior cerebellar artery, anterior choroidal artery and posterior communicating artery. Next, if there is a lesion in the pons. Pons means the nucleus of 5th, 6th, 7th, 8th cranial nerves are present in the pons. Okay. So, in that also we will get lesion, hemiplegia in one side and cranial nerve involvement in the side of the lesion. So, in pons also we have some pontine symptoms like Maillard-Guebler syndrome, Raymond-Fovili syndrome all. In a Maillard-Guebler syndrome, we will get ipsilateral 6th and 7th nerve palsy plus contralateral hemiplegia. Okay, ipsilateral 3rd and 6th and 7th nerve palsy plus contralateral hemiplegia. Then Raymond-Fovili syndrome. So there will have ipsilateral 6th and 7th nerve palsy plus PPRF. PPRF is the paramedian pontine reticular formation and so that will be affected. So that this is involved in the coordination of eye movements. Then there will be contralateral hemiplegia. And the blood supply of the pons is pontine branches of the basilar artery, superior cerebellar artery and anterior inferior cerebellar artery. Okay, that is pontine branches of basilar artery, superior cerebellar artery and anterior inferior cerebellar artery. So now most of the people have doubt in the facial nerve involvement, that is UMN and LMN lesion. Okay, facial nerve. This facial nerve have nucleus. It has one nucleus at the level of the pons and another one nucleus above the pons. That is most commonly in the internal capsule. Okay. So if it is a lesion above the pons, so that will be a UMN type of lesion. And if it is at the level of the pons, if the lesion is at the level of the pons, that it will be a LMN type of lesion. Okay. So now coming to the first of all, we will discuss what is normal. Okay. See that here. So we have a nucleus. A facial nerve has a nucleus at the level of the pons. Okay. And it also have a nucleus above the pons, that is most commonly at the level of the internal capsule. So from internal capsule, so from above the level, it also sending fibers. Okay. See here, from above the pons, so one fiber is going to the, two fibers are going to the opposite side and one fiber is coming to the same side, upper part of the nucleus. Okay. So this facial nucleus at the pons has an upper part and a lower part. So from the nucleus in the above the pons, so one fiber is coming to the same side of the to the same side facial nucleus into the upper part. Okay. Now see the some two fibers are going to the opposite side. One is going to its upper part and one is going to the lower part. Okay. So now think, if there is a lesion in the upper part, if there is a lesion in the nucleus, if there is a nucleus that is present above the pons, that is nucleus that is present above the pons. Here, so these two fibers will be cut. This will be cut. Okay. This also cut. But look here. This nucleus is also, this facial nucleus of this side is also getting fibers from the opposite side. So this will not be affected. So this will not be affected. This side will not be. The same side of the face will not be affected. This side will not be affected. Okay, this will be normal. Okay. Now look to the opposite side. In the opposite side, it is this fiber. It is the upper part is also the lower part is getting only fiber from the opposite side, but the upper part is getting fiber from the same side. Or this side has no any problem. Okay, this side is not having any problem. So here the upper part will be, lower part will be lost, but the upper part will be present in a UMN type of lesion. In a UMN type of lesion, upper part will be present because the upper part is getting fiber from the same side. Here this nucleus is not affected. Okay, only this nucleus is affected. So the upper part is not having any problem. Since the lower part of this nucleus is only getting fibers from the opposite side, here the lower part is affected. Okay. Now coming to the, if this is a lesion at the level of the, if this is a lesion at the level of the at the level of the pons. See, if it is a lesion of the pons, so this same side, this will be lost, this will be lost. Okay, this will be, these two will be lost, and the so both upper part of the face and the lower part of the face will be lost in a element type of lesion. If it is a UMN type of lesion, only if it is this, since this facial nerve nucleus at the level of the pons is a element type of lesion, here the same side of the face is affected and both upper part and lower part is lost. Okay, if it is a lesion in the upper part, sorry, if it is a lesion, it is a UMN lesion, only upper part, only lower part is lost, only this part is lost, this upper part is intact. Okay, understand this. Okay. Now coming to the medulla. Medulla, we have nucleus of 9, 10, 11 and 12th cranial nerve. So here we have cranial nerve involvement on the side of the lesion, and there will be a contralateral hemiplegia on the opposite side. And the blood supply are vertebral artery and posterior inferior cerebellar artery. These are supplying the medulla. Now coming to the medullary syndrome. So some symptoms are Aphasia syndrome, Jackson syndrome, then medial medullary syndrome, lateral medullary syndrome. Aphasia syndrome means there is 9th and 10th cranial nerve paralysis on the same side of the lesion and contralateral hemiplegia. Okay, 9th and 10th cranial nerve. Here 9th and 10th cranial nerve is involved. Okay, next is Jackson syndrome. Here 10th and 12th cranial nerve on the same side of the lesion and contralateral hemiplegia Next is the medial medullary syndrome. Medial medullary syndrome, there is occlusion of the anterior spinal artery of the vertebral artery. There is occlusion of the anterior spinal artery of the vertebral artery. In a medial medullary syndrome, medial meniscus is affected, corticospinal tract is affected, and the 12th nerve nucleus or its fibers are affected. If a medial meniscus is affected, there will be contralateral loss of the proprioception, touch, pressure, vibration sense all. And the corticospinal tract, so we have contralateral hemiplegia. And 12th nerve is affected, so there will we have ipsilateral element type paralysis of the tongue. Element type paralysis of the tongue. Next is the lateral medullary syndrome. In a lateral medullary syndrome, there is occlusion of the posterior inferior cerebellar artery. There is occlusion of the posterior inferior cerebellar artery. So here, in the same side of the in the same side of the lesion, will spinal nucleus of the 5th nerve involved. So there will be ipsilateral pain and temperature loss in the face. So in the trigeminal nerve that is involved in the facial in the face, so there is ipsilateral loss of pain and temperature of the face. Next is the spinocerebellar tract. So there will be ipsilateral limb ataxia. Then there will be sympathetics involvement. So there will be ipsilateral Horner syndrome. Ipsilateral Horner syndrome. Then there will be involvement of the fibers of the 9th, 10th cranial nerves. 9th and 10th cranial nerves. So there will be dysphagia, hoarseness and diminished gag reflex. And there is involvement of the nucleus tractus solitarius. So there will be loss of the taste. Loss of taste. Then involvement of the vestibular nucleus. So this will lead to vertigo, diplopia, nystagmus and vomiting. And in the contralateral side, due to the spinothalamic tract involvement, we will get a contralateral loss of the pain and temperature. There will be contralateral loss of the pain and temperature. So with these basic things, you can understand, you can localize where is the lesion is. So if a patient is coming with a dense hemiplegia, so if a patient is coming with dense hemiplegia and there is hemianesthesia, so we can directly go. Where will be the lesion? It will be a lesion in the at the level of the internal capsule. Okay. So if there is a cranial nerve involvement in one side and paralysis of the opposite side, so here the lesion will be in the side of the so here the lesion at the level of the brainstem. Okay, these are some basic things that you required for how to localize a stroke. So I think then you can read much more. So I just discussed only some basics. So then you can easily understand. So thank you.